Hey everybody, today we're going to talk a little bit about COPD, and before we move on to the next slide, the reason why I use this umbrella because I try to get students to understand that COPD is kind of a umbrella term for individuals that have a chronic respiratory condition that typically is a combination of both emphysema and chronic bronchitis. So a lot of these patients have a combination of both, and they're lifelong, and the damage that occurs is not reversible. So chronic condition, the best that you can do in the role of a nurse is supportive, teaching patients how to slow down further damage and progress of the disease and to help improve their quality of life. But there will be nothing reversed once somebody actually has this diagnosis because of the damage that has already been done. So let's move forward. So the epidemiology of COPD, it is considered a chronic obstructive pulmonary disease characterized by chronic airway limitation. Like I said, that is not reversible. 13.7 million Americans have it. The annual cost is astronomical, approximately $50 billion a year, and it is the fourth leading cause of death in America. Pathophysiology, inflammation and narrowing of the airways that leads to loss of pulmonary function. Emphysema, which is a grape-like cluster at the end of the bronchioles that become abnormally enlarged with destruction of the alveoli. So think of it's hyperinflated, and so because of that, gas exchange cannot occur. Chronic bronchitis, usually patients have a productive cough that is present for 3 months in a 2-year period. They have chronic mucus, hypersecretion, which again causes a decline in the function of the lungs and can exacerbate infections as well. So some important things to remember with these patients is that they have impaired gas exchange. So in dealing with these patients, want to look at some of their lifestyle choices. So if they are still smoking, they need to stop. They need to avoid those who smoke. Use proper protection when around those that are contagious to lessen upper respiratory and lower respiratory infections. And these individuals should also get both their flu and pneumonia vaccinations. So as you can see by the background, if you're not familiar with this is, just to really kind of push the point, it is a bunch of cigarettes, that smoking is the primary risk factor for COPD. Aging, individuals can have a decreased pulmonary reserve, just related to normal lung changes, and this also exacerbates with asthma. Those depending on their occupation, dust and chemicals, indoor and outdoor air pollution, and some too may have a genetic component to them of this alpha-1 antitrypsin deficiency. Also too, which is interesting, is that newer research is showing a leak of obesity, putting individuals at risk. So some of the manifestations are dyspnea, a chronic cough, and sputum production. Diagnosis is based on lung function testing. Diagnostic criteria is a FEV1 of less than 80 and the FEV1 over FVC ratio of less than 70, which is also kind of comparable to asthma as well. Expected findings with patients with COPD, There's two sides here, those common and those in the late stages of COPD. So it kind of depends. So they have difficulties where they feel like they're always having this exertion of shortness of breath, productive cough, hypoxemia, basically is low oxygen levels, crackles or wheezes, and breathing that is going to be shallow, and you can see them in using accessory muscles. When you're seeing patients trying to breathe, the type that's going to be most beneficial for those with COPD is to teach them how to do pursed lip breathing, where they're kind of pursing their lips together. It basically helps one, cause some tension, but it helps to lengthen out the expiratory breathing, and it makes it more effective for them. So pursed lip breathing is always going to be very important for patients with COPD. This will give you kind of a picture of what a barrel chest looks like over time. And this individual, which is kind of a good picture, they're not particularly overweight, but you can see over time using those accessory models how it kind of reshapes their chest. So this is a really good link here. If you please have time to just read it, it's a good article. But if you ever hear in the hospital, there might be some terms of blue bloaters versus pink puffers. And nowadays, these terms really are politically incorrect. You shouldn't use them. But they were descriptive terms for individuals, whether they were having more of an issue with chronic bronchitis versus emphysema. And it's kind of a stereotype, but is not really a one-size-fits-all descriptor. So some folks who may have emphysema aren't necessarily thin, but they can have their skin kind of has a pink appearance to it, where those with chronic bronchitis may have a little bit of a bluish appearance. But read this article. Like I said, it's not very long, but it gives some really good information about the descriptors. And obviously, descriptors of individuals come from some basis of truth, but again, it's not a one-size-fits-all. So just kind of want to give you that information. So laboratory and diagnostics testing, you can have increased hematocrit just due to lower O2 levels. Sputum cultures can trigger, or not trigger, but point towards an infection. White blood cell count can also help determine infection. ABGs, hypoxemia, you may see a decrease, O2 less than 80. May see increase in your CO2 greater than 45. May see some things with their electrolytes disorders. Pay particular attention to sodium and potassium, which again, during this whole class, we've talked a lot about sodium and potassium. And I'm sure you're probably laughing, going, oh my goodness, what is it about electrolytes? So think about it with, so in terms of sodium and potassium, typically patients with COPD may have other comorbidities going on. Sodium levels may be lower in some COPD patients just because they may also have heart failure, fluid retention, and so that is going to hold on to fluid and cause the dilutional hyponatremia. Potassium levels could potentially be low just for the use of certain medications like theophylline, your beta agonists, and also use of diuretics. So those are the two that you typically should kind of be thinking about when you're dealing with patients with COPD. Other diagnostics, as we talked about, with the ratio of forced expiratory volume compared to the forced vital capacity. So at about 70%, you might be having mild COPD. Those less than 50, moderate to severe. So typically 70 and below, we're going to have an issue. Chest x-rays can show that inflation of the alveoli and the flattened diaphragm. Pulse ox can show a low O2 sat, and again, where there can be some possible genetics of the AAT levels. When levels are low, patients typically have a higher risk of having COPD. So for patient care, it's going to be education, positioning them, encouraging cough, turn deep, breathe, oxygen as prescribed, caution with some O2 administration. The rule of thumb is if they can benefit from O2, don't deprive them. There's some concerns about knocking out their O2 drive. We will talk more about that in critical care. But again, if they can benefit, do not withhold. Breathing treatments and other medications as prescribed. Watch for their skin breakdown. Promote adequate nutrition. Depending on their severity of COPD, it takes a lot of effort to eat and breathe. And so you have to encourage these individuals high protein, eat small meals frequently. But it's really tough, and so you need to give them some patience and also monitor their weight and note any changes, because again, there's a lot of comorbidities that go on with this. And also practice breathing techniques. You can look in your Honan book, but again, remember, pursed lip breathing is going to be really important for your COPD patients. So to kind of help them to remove airway secretions, they may use a flutter valve, and this will give you some steps of how it's actually used. Exercise conditioning, this will help improve their pulmonary status by strengthening the lungs. Basically, you want to talk to them about walking until they start having shortness of breath, to rest and resume once it subsides. Try to walk 20 minutes daily, 2 to 3 times a week. Tailor the exercise for older individuals. Again, be supportive, encourage, and also, like we talked with a lot of respiratory issues, is to increase fluid intake, 2 to 3 liters a day, to help keep secretions thin, to make it easier for them to cough up. Make sure you can educate patients about how to use incentive spirometer. It helps promote lung expansion. Show the patient how to use it. Tight seal with their mouth tightly around the mouthpiece. Inhale and hold the breath. And while the client inhales, the needle of the machine will actually rise. And then need to try to practice this every hour while awake, at least 10 times an hour. And they need to inhale slowly. So make sure that you can certainly teach a patient how to use this. It's important just in COPD, but those coming out of surgery, especially anybody in surgery that's had anything done to their chest or abdomen, not in addition to, even with coughing and breathing, is to make sure that they splint any incision. And I think we did talk about that back in peri-op, which feels like it was so long ago. Some medications, I went a little bit more in depth in your asthma slides, so make sure you review there, but make sure you understand your bronchodilators, anti-inflammatory, and mucolytics. And here's a little bit of a breakdown with the different types. I know we talked about theophylline several times. Just make sure that patients understand the toxicity signs and symptoms and to report them, which are tachycardia, nausea, and diarrhea. So make sure you educate those patients. And also, too, for those who are using cholinergics to report a headache or blurred vision, and patients using things like albuterol, they may have tremors or tachycardia. So they kind of correspond here. So 1 to 1, 2 to 2, 3 to 3. So make sure you know those highlighted points. Corticosteroids, again, watch for good mouth care and not to discontinue suddenly. And anti-inflammatories, we talked a little bit about over in asthma. Mucolytics, those help to thin secretions, and when patients are on those, they need to increase their fluid intake, which most, I wouldn't say all of you, but if you've ever had a cold and taken things like Mucolytics, which is a mucolytic, you have to make sure you increase your fluids. O2 therapy targets for those, a lot of times going to be between 88 to 92. The targeted approach is associated with a decreased mortality in COPD patients and less respiratory acidosis. And the oxygen flow rate administered is not important. Basically, what we're trying to do is looking at the alveolar, the PaO2, and indirectly the SAT levels is achieved. And again, I think I've already said it 2 times, maybe this is the 3rd or the 4th, never withhold oxygen from a seriously ill hypoxic patient due to fear of cause of hyperkinetic respiratory failure. And again, O2 should not be held if the patient can benefit. Education, watch for those in red or highlighted here. Importance of high calorie, high protein diet. Hand hygiene, just because we want to decrease the risk of infections to exacerbate their chronic condition that cannot be cured. Rest periods, stop smoking, stop smoking, stop smoking, number 1 risk. The importance of taking medications, proper use of inhalers and spacers, and the use of an emphysema spirometer. Vaccinations. Talk to them about use of oxygen and that it's flammable and not to smoke around it. And of course, be supportive. Complications, respiratory failure, respiratory infections. We'll talk a little bit about respiratory failure, and then right-sided heart failure. Cor pulmonale results, unfortunately, because the lungs vessels or the lungs or the pulmonary vessels have become diseased or remodeled. Air trapping occurs, collapses, and the stiff alveoli can lead to increased pulmonary pressure. Therefore, blood flow through the lungs becomes difficult, which causes the heart to enlarge in the right atrium and the ventricles. So these are going to be our signs and symptoms of right-sided heart failure. So make sure you're familiar with them and that it is a complication of COPD. Recognize a respiratory failure. Those individuals will need intensive care. Severe shortness of breath that does not respond to treatment, which is very similar to asthma attacks. Person can have rapid breathing to slow breathing to no breathing. Hyperventilation declines to rapid shallow breathing. They become very anxious, they can't breathe, which is very similar to an asthma attack as well. I mean, anybody who can't breathe will become very anxiety-ridden and irritable. Can have level of conscious changes. Worsening hypoxemia that does not respond to O2 therapy. Patients can have muscle fatigue, the increase in those accessory muscles, and so this typically leads to a need for ventilation mechanical ventilation. Respiratory infections can make COPD worse, so make sure you give the patient O2 as needed. Remember to get blood and sputum cultures before administering antibiotics. Educate your patient to avoid crowds, and again, get vaccinated. If you have any questions, again, make sure you use the Test 5 question board appropriately, and I hope this helps you focus your studies and reading. Take care.